Hi, and welcome back to JNO Network Open Live. I'm Seth Kruger, Digital Media Editor of JNO Network Open.
Hi, good afternoon. I'm Mike Berkowitz. I'm Electronic Editor for JAMA and the JAMA Network.
And today, the first paper we're talking about is the comparison of costs of care for Medicare patients hospitalized in teaching and non-teaching hospitals. And we've got our guest author, Dr. Laura Burke, joining us today. Welcome, Laura.
Thank you for having me.
All right, so why don't you tell us a little bit about yourself and why you're interested in this research question?
I'm an assistant professor of emergency medicine at Harvard Medical School and an attending emergency physician at Beth Israel Deaconess Medical Center. And I work with Ashish Jha at the Harvard School of Public Health. And we started talking about this topic several years ago. As healthcare has transitioned to value-based payments, there's been concern that teaching hospitals may not provide the best value. A lot of the discussions around care at teaching hospitals has suggested that teaching hospitals are more expensive, but have not provided better outcomes. And this really conflicted with prior literature, at least on the outcomes front. And we had done some work looking at differences in mortality by hospital teaching status. And our work had suggested that, much like previous studies decades prior, that teaching hospitals actually had lower mortality on average. But one of the questions was, how do they fare with respect to cost? There have been prior studies that say if you just look at the initial hospitalization, you might miss the broader picture when it comes to costs. And that's the idea behind bundled payments, is that you really need to look at an entire episode of care. And so what we did was we looked at costs of care for teaching hospitals. We looked at the same 21 conditions that we had used in our mortality studies. And we asked the question, do teaching hospitals, how do their costs fare? And again, this is just among Medicare patients. And we looked at both the costs of the initial hospitalization and downstream costs to look at total costs of care at 30 and 90 days.
Okay. Yeah, and I found it really interesting. So this was basically data from the Medicare file from 2015 through 2016, pretty much. And what was really fascinating to me was how the inpatient costs were slightly higher at the index admission, so the hospital costs were higher, but then basically there was a difference in the post-acute care, the post-discharge costs. So tell us about that.
Sure. So because it's Medicare, Medicare is paid based on a DRG payment. So the people ask the question, well, why would it be different at all? You really should get exactly the same payment. But actually, we noticed that teaching costs were higher, or total hospitalization costs were higher at major teaching hospitals. And we looked into it. If you look at the formula for inpatient payments, some of the difference is driven by outlier payments. So these are the type of patients that might have a 30-day ICU stay. It's really unusual. They're particularly sick. And so Medicare recognizes that their costs of care are higher and has this additional outlier add-on payment. When we removed patients who had any of those outlier payments, the difference was more narrow. But there are other payments that are in the standardized cost methodology, like technology add-ons. But the difference was small, and it was largely driven by outliers. But then when we looked at post-discharge care, we did this in two ways. First, we just looked at what was the total spending. And we found that teaching hospitals had lower readmission costs and lower post-acute care costs. And so we looked at that in two ways. We asked, is that because they're having fewer readmissions, or are they just being readmitted for cheaper types of DRGs? And the answer was actually both. They had lower odds of having any readmission, and when they were readmitted, the mean cost per readmission was lower. And the same was true for post-acute care. And this is consistent with work that Tom Tsai, he's a surgeon who had worked with Ashish in the past, and they had found that high-quality hospitals had higher upfront costs, but lower post-acute care spending. And again, when you look at the total spending, there was actually savings to Medicare that you might miss if you looked at just the initial hospitalization. And so that was in surgical patients. So the idea was that maybe you might have fewer complications. We don't know if that was the reason for lower readmissions or post-acute care, but we did find a similar pattern of spending.
Yeah, and I think that reinforces a lot of the work that I've heard Karen Joint-Maddox do or talk about in this, that basically for the bundled surgical packages, pretty much all the savings, all the cost difference is in the post-acute services. And if we show your figure 2 here, you can see the index hospitalization, the costs are higher at the teaching hospitals versus the minor teaching hospitals versus the non-teaching hospitals, but then all the post-acute services are the exact opposite way.
Right.
Yeah.
Right.
And there's a difference between medical and surgical admissions?
Yeah, so we in general found similar patterns, but the similar patterns of higher upfront spending and lower post-acute care. But when we looked at individual medical and surgical conditions, there were some differences across the groups, but the overall patterns were fairly similar.
Right. And I think looking at the whole package kind of is and the numbers you get with it are interesting to me because, when I think of the big academic medical centers, the big teaching places, there's a big focus on, fancy surgical procedures, complex robotic surgery, that kind of stuff. And there's actually a bigger difference in the cost for the surgical patients than the medical patients.
Right.
Yeah. And so just to clarify, the teaching hospitals had lower costs than the non-teaching hospitals for surgical patients, more so than they did for medical patients.
Right.
Huh.
Yes.
Yeah.
And so you mentioned earlier that this might point towards payment reform, towards bundled payments, episodes of care rather than fee-for-service. Can you talk us through that a little bit more? How do these data kind of point in that direction?
Well, if you think about, say you're skimping on care in the hospitalization setting, you're just pushing patients out and just, reducing your length of stay to maximize your profits. If then you have downstream spending that's even higher, that might not be captured if you're just paying for the inpatient hospitalization. But if the provider who provides that initial care is on the hook for the whole episode, there's an incentive to improve coordination, to make sure you do the right thing for the patient and aren't just pushing the cost down the line.
Got it.
And I'm an emergency doc, so I'm not sending a lot of patients to post-acute services. I'm mostly getting patients to the hospital.
Right.
So I don't deal with this on a day-to-day level. But from most of what I've read, a lot of the variation in post-acute services seems to be mostly just kind of institution dependent, more cultural than anything else. Probably some financial incentive stuff involved, whether or not the hospital owns the post-acute facility that they send their patients to, and things like that.
Right.
And that the idea with bundled payments is that the hospital's on the hook for the whole episode of care, including the post-acute care. They have to make sure they're, and there's quality metrics about readmissions and things like that. They have to think about, does this patient need to be in the hospital longer? Do they need post-acute services? Are they best off with neither or both?
Right. So they're making global decisions in context for the patient.
Right.
Makes sense.
Yeah. The other thing, one of the things I really liked about this paper is, the first thing I feel like most health policy people hear when they hear somebody talk about healthcare cost is, well, what do you mean by costs?
Right.
Do you mean the charge? Do you mean what the hospital actually costs as far as how much resources are? And this is just very deliberate. This is what Medicare paid to the hospitals for the services, and it's about as concrete as you can get.
Yeah, that was some of the debate that came up when we were discussing on Twitter is, what do you mean by cost? We're not measuring how efficient the hospital was, what their margin was in terms of the Medicare payment. This was the cost to Medicare and the cost to taxpayers through Medicare for providing that service. So the cost to Medicare and the spending that they had.
Yeah.
And what was the conversation about these findings on Twitter? You said you hinted that there was a spirited debate.
There was. It's been a lot of fun to get feedback on it, and that's the best part of all of this. You spend so much time, and then you get to get the feedback on it. So a few things. There was, what do you mean by cost? And literally what we mean is Medicare spending. And of course, people raise the important point that this is different than what may happen for the commercially insured, where there's wider price variation. That we don't have that in Medicare. But really what we wanted to point out was the utilization patterns. When you just look at the index hospitalization, you miss that there's lower spending after the hospital stay, and that leads to lower spending at 30 days on average for Medicare patients. Whether or not that would be true for commercially insured patients, we don't know. We would have to do that study. But that was one of the concerns or critiques that people had, is this may not be generalizable to that population. But Medicare is a big payer for hospitalized care. So I think the findings are important, but that limitation is notable. The other point that came up was indirect medical education payments. So in our paper, IME payments are payments made to the hospital on a per hospitalization basis, and it's based on teaching intensity, and it's to compensate hospitals for costs associated with being an academic medical center. So, the potential inefficiency of training residents, for the standby capacity that's required. And so when you do include IME payments, the costs are higher at teaching hospitals, but there's been a debate. Should you include that? It's certainly an extra cost to Medicare per hospitalization, but some have argued that it's really not about the clinical care. It's about providing support for training the next generation of residents and for hospitals to have all the necessary services to provide that care. So it really is, we thought it was important to provide both sets of numbers, because what you do with those numbers is really a value judgment, and we are grateful that we were able to kind of approach it from both angles. One's a clinical care, one's a payment policy issue, basically.
Right.
Right.
Fabulous.
Yeah, and it was interesting to me how that IME question, the difference in numbers basically dwarfed the differences in the actual clinical numbers too. But at some point, I'm going to get old and need to be in a hospital, and I'd like there to be trained doctors who can take care of me.
Right.
So,
Yeah. If
Yeah.
Medicare's around, which we expect it to be.
Hopefully.
some form or other.
Yeah.
Yeah. Okay, great. Well, thank you for joining us. It's been great talking
Thank you
to
so much.
Thanks for the paper, and thanks for submitting it to JAMA Network Open.
Thank you so much.
A pleasure. What do you have next?
Great. So next up is the availability and cost of naloxone nasal spray at pharmacies in Philadelphia, Pennsylvania in 2017 by Jenny Guadamuz and colleagues, which includes Dr. Dee Macedo, a pharmacist who joined us a couple weeks ago,
Right.
talking about pharmacy closures in Philadelphia.
Right. Right. So this is interesting. This is about the kind of public availability of an opioid antagonist in a city that is known for its opioid public health problems.
Right. Yeah. So this is really interesting. So basically, one of the things I learned from this paper is
Yes.
that every state has passed some sort of law expanding access to naloxone, basically either a statewide standing order or the ability for pharmacists to prescribe naloxone or some other types of laws that I don't remember the details of.
Right.
And Philadelphia or Pennsylvania, the state of Pennsylvania in 2015 passed a statewide standing order. Basically, everybody essentially has a prescription to naloxone, and you can walk into a pharmacy and it's not over the counter per se, but you can basically functionally it's over the counter because you can say, I want this naloxone.
Right, but that's actually something I was hoping for clarification on. I thought maybe you could explain, or an author can, but maybe we'll put it out there, what the difference is between pharmacy dispensed medication without a prescription and over-the-counter availability. Why wouldn't you just make it available over the counter as a public health policy?
I don't know the answer to that question, but my guess is just it's a workaround around the laws where making something non-prescription where it can just be over the counter requires certain types of steps, and the state government may not be able to do that without rewriting a whole bunch of laws. So just saying, all right, it's still whatever status was, but now everybody has a prescription for it functionally.
And the other reason that I speculate is because there's an educational component, when and how to administer, and that needs to go through a human. I imagine the legislators are kind of trying to incentivize. But as we learn here, I think it may not be the most effective way to get the drug into people's hands and to educate people how to use it.
Right. So what these authors did was they did a survey where they basically contacted 92% of the 400 or so pharmacies in Philadelphia and asked them a few questions. Basically, do you have naloxone available in your pharmacy? Am I able to get it without a prescription, which is what the law is? And then some other things like what would the out-of-pocket cost be? They, again, 92%, pretty good response rate.
Right.
Better than any survey I've done.
And I think in some instances, the investigators or volunteers or research staff actually walked in and talked to pharmacists posing as patients.
Right.
And this kind of got a waiver for human subjects research. So they were able to do it because they were just asking about information that should have been publicly available from these pharmacies anyways.
Right. But unfortunately, the bad news is only about 1 in 3 pharmacies actually had the naloxone in stock. So it doesn't matter how legal it is to buy something. If the stores don't carry it, you can't get it.
Right.
And number 2 was that 61% said that 61% said that it was available without a prescription, meaning about 40% still required a prescription, even though the law said that you didn't actually need a prescription. So whether this was just, I guess, for lack of a more polite word, ignorance on the side of the pharmacies that the prescription was needed, or the pharmacy just adding their own burdens to dispensing naloxone is a little unclear. But that's still 4 out of 10 pharmacies are still requiring a prescription.
Right. And then the other finding that I was intrigued by, not in necessarily a favorable way, is that the median out-of-pocket cost for naloxone nasal spray without a prescription was $145.
Right.
That seems like a lot of money for most people.
Right.
And who knows what the stereotype is of an opioid user. There may not be one anymore because it crosses all demographics. But that's still a lot of cash to pay out at a pharmacy counter for a drug that you may or may not use in the future.
Right. And that's actually, again, I'm not an expert in pharmacy law. But one of the things that I've heard come up in conversation of things like, say, making birth control over the counter is that if it doesn't require a prescription, then insurance companies have less of an incentive to keep it on the formulary and cover it.
Right.
And so that might be part of the reason why the legislators kept it as far as a standing order instead of a over-the-counter availability.
And again, I'm going to kind of point direct questions at you that you may not be best positioned to answer. Is the intent that people who have opioid use disorder pocket this and keep this on hand, or is it for family members of concerned patients, or is it one of the above, or anybody who wants it? Right?
Yeah, I think it's at all of those. I think it's a both and, not an either or. But basically, part of it is I think there's some expectation, and I would imagine some data, although I don't know this stuff, that people who use opioids are probably more likely to know other people who use opioids.
Right.
You know, behaviors tend to be contagious in one way or another.
Right.
Or, you know, if you're worried about a family member or you have a family member with cancer who's on high doses of pain medications, et cetera, that you might be able to get one. And I also know, you know, obviously I travel in certain circles, but I know some docs who just, you know, keep a nasal naloxone on, you know, in their wallet or not in their pocket, on their purse, in their car all the time, just in the chance that they happen upon someone on the street, kind of like people carry mouth-to-mouth masks.
Really? That's interesting. So let me pivot that and ask you about ED policy,
Sure.
at least at your institution. So I imagine Northwestern's ED sees opioid toxicity.
We do, as a matter of fact.
Are you handing to those patients or their families in the ED these antagonists?
We are. We have a naloxone dispensing program.
Okay.
It's relatively small. We probably don't do it as much as we should. But we actually, I think it's through a small grant. We got basically a small, we don't even have prescriptions. We got an actual supply of naloxone nasal spray to give to people.
Really?
Yeah.
Okay. So let me just go on a flight of fancy. If I
Sure.
were to do a study of emergency rooms in the Chicago area or in Philadelphia and how many opportunities they are seizing or missing to prescribe this medication to people who are defined as high risk by being in the ED, either by volunteering a history or by having clinical opioid overdose, I imagine there's, you know, that we would kind of find similar results.
Right, absolutely.
Is that
And
fair?
there's certainly, I'd say, I'm an optimist. There are opportunities for improvement here.
Yes.
And I think this is the kind of stuff that's best done on a systems level. So,
Right.
you know, it's not that I need to think, oh, wait, this was a patient who was signed out to me as an opioid overdose who got naloxone a few hours ago. I should discharge them next. It's when I print out the discharge papers with, you know, this list of diagnoses, it triggers, you know, an option in the HR to prescribe or something
Right.
like that. I think that would be a great way to do it.
Right. That's
I-
the opt-in
Yeah.
kind of behavioral economics
Right.
system.
Yeah, I think that's really the best way to do it. We're also seeing some movement kind of across the country with buprenorphine or Suboxone prescribing, where we're actually starting a program in our emergency department to do buprenorphine prescribing in high-risk patients as well, to dispense. Or I don't think we can dispense, but I think we can do dosing in the ED. A lot of my colleagues have been working on getting X waivers.
So you would start the patients in the ED on their chronic maintenance therapy to
Yep.
treat their
Yep.
use disorder.
Yep, and get people plugged into therapy and work on getting them a bridge prescription for the time between when they see us and when they can get into long-term therapy.
Got it.
Yeah.
Wonderful.
So it's good stuff. Again, you know, there's a lot of bad things about the opioid epidemic, but it's been heartening to see a lot of people like working really hard to make the world a better place now.
Right. And we have a number of really good resources across the JEMA network. We have a patient page in JEMA Internal Medicine for patients who might have opioid use disorder and or people who are taking care of them. There was a great review in JEMA Psychiatry by Nora Valco, who's the director of NIDA in the NIH, giving a kind of a full scientific review of the pathophysiology of addiction and the management of addiction, and lots of other, obviously, resources, including the CDC guidelines. We have a website, if you just search for JAMA Network and CDC opioid prescribing guidelines that were published in 2016, so they're already a little dated. We're a little controversial, but there's a lot there, so check out our opioid collection at jamanetwork.com.
Yeah, and of course, as Dr. Burke said, she and her group did publish a paper in 2017 in JAMA on the comparison of mortality between teaching and non-teaching hospitals. So it's Burke 2017. JAMA.
Okay, so that's a follow-up,
Yeah,
not about
I'm
opioids, but
circling back to the beginning as we transition to our next.
yes, the circle remains
Next part.
unbroken.
Yeah, absolutely. So last, we're going to do our table of contents rundown. First, and probably most importantly, the best opportunity is we're having a call for papers on understanding and improving palliative care and care near the end of life. Basically, JAMA Network Open we've been getting some great end of life and palliative care papers, and we want to encourage that. There's a lot, again, a lot of opportunities for improvement here,
Yep.
and our journal is very open to publishing reports of innovations and things like that.
Great.
So-
So submit your stuff to JAMANetworkOpen.com, where there's instructions for authors. And Fred Rivera and Steve Finn and the editorial board will probably be sympathetic, if that's the word, to end-of-life papers.
Yep, certainly encouraging.
Yes.
Next up, assessing the safety of direct-acting antiviral agents for Hep C. So the last, I think it's 7 years now, there have been some direct-acting agents for Hep C. I can't pronounce the generic names, but basically Solvati and Harvoni are the two big ones. And I'm not supposed to say brand names.
Is it? Yes, you're not supposed to say brand names, but okay.
But
Sofosbuvir or something?
something like that. There's a
Okay.
sauce in there somewhere. And most of them are combos too. And
And I'm going to say they're safe.
Yeah, absolutely. Again, this is not something I know a ton about, but apparently there is a black box warning on some of them because there were about 1,500 patients whose liver processes got worse, although that's not terribly surprising that people with Hep C got worse
Right.
liver problems. There were some concerns raised about their safety. But these authors looked at a big database of 34,000 patients and actually found that patients who were getting these new Hep C drugs had lower rates of death, lower rates of most of the bad liver outcomes that we worried about, lower rates of multi-organ failure, lower hospitalizations, lower ED use, all sorts of good things. And basically, although some of it's probably some selection bias for the patients who are able to take these medications are probably on the healthier side of the spectrum than some of their peers, there's not a signal towards worsening harm.
Right. And my overall gestalt is that was the case. I mean, these were blockbuster drugs,
Yeah.
and we took a kind of a considerable amount of time to get the population with chronic hepatitis C on them. But they've been revolutionary. They actually create sustained viral response and have made chronic hepatitis C basically a livable disease, right?
Yep, absolutely. So it's really amazing. What a time to be alive.
Yeah.
The next up, a less positive study, but
But you're still optimistic.
I'm still optimistic. I've got a nice, I'd say, a cynical optimism.
Yeah.
So these authors looked at U.S. Army soldiers and suicide risk and access and availability of firearms. So they looked at a couple of different populations. They looked at about 130 or so soldiers who did commit suicide, who died. They talked to a bunch of supervisors of these soldiers. They talked to next of kin of these soldiers. And they talked to another group of 100 or so soldiers with suicidal ideation, and basically did some qualitative stuff, and then also did some data analysis on things like access to guns. Did they have guns in the home? Did they have loaded guns in the home? And found that, not surprising, the soldiers who died were more likely to have had access to guns. Basically, this kind of reinforces a lot of what we already know, that the soldiers with handguns were more likely to complete suicide. That people who kept the guns loaded in the home were more likely to commit suicide, and that soldiers who walked around when they were off duty carrying a gun were more likely to commit suicide.
And what was the comparison? Because they obviously completed suicide, sadly. Was it the comparison soldiers or veterans who were ideating suicide but didn't have?
I think that was the main comparison.
Okay.
Yeah.
Okay.
So it's interesting. It reinforces a lot of what we already know, that basically guns make acute end to a chronic end to the acute condition of suicidal ideation.
A permanent solution to a temporary problem.
Right. Yeah, that's much more elegant and sad.
Right.
There's some other stuff in there where things like the long guns, like shotguns and rifles, didn't reach statistical significance, which might have been because of small ends. It might have been just because people who have, say, a hunting rifle at home or having a hunting rifle at home is different than having a handgun at home, and all the other things that go around with that.
Right. Well, the Veterans Administration has a lot of resources for these guys, but not reaching them, obviously. And one of the issues, there are mechanisms in place in communities, and I think it's an emerging public health policy to try and get guns out of the hands of people who are at high risk, either for completing a suicide or a homicide. But I think in these instances, people don't let others know that that they're in possession of a gun, so it's hard to stage an intervention then.
Yep, it's tough. One of the positive things here was that the safer gun storage at home, so things like gun locks, did seem to be somewhat protective or associated with lower rates of completed suicide. So kind of like we talked about about last week with the video games, safe storage seems to be truly safe and helpful, and something that we can work on.
Great. What's next?
Next up, so this is really interesting. They looked at patients who had pneumonia and the subset who had alcohol use disorder, and basically did some interesting statistical analysis of what sort of comorbidities they had, what sort of bugs they grew when they grew out positive cultures, and honestly, it challenged a lot of what I think we knew about people with alcohol use disorder and pneumonia. So not surprisingly, they were sicker, they stayed in the hospital longer, they were more likely to have respiratory failure, need the ICU, et cetera, ventilation and what. A lot of that seemed to be associated with withdrawal complicating their pneumonia, and not the alcohol use disorder making them sicker. Because when they adjusted for comorbidities, a lot of the differences, or some of these differences were attenuated. But most interesting to me was the aspiration rates were about the same. They were almost identical.
Between people who had alcohol use disorder and not?
Yeah, so
that contravenes everything we learned.
Right, and that's not even the most amazing thing.
Okay.
So the most amazing thing is that so the culture rates, the growth rates were a little higher in the alcohol group, but the
growth of anaerobic bacteria,
growth of any bacteria in cultures.
Okay.
Which overall growth rates are pretty low for pneumonia.
Yeah.
So
anyways,
but when they were able to isolate the bacteria, it was the patients who did not have alcohol use disorder who were more likely to have resistant bugs.
That's a surprise. What's the sample? What are the hospitals? What regions?
Yeah, it was a premier healthcare database. It was a big database of 140,000 patients.
Is it intended to be nationally representative?
I don't know off the top of my head.
Okay.
But it was 140,000 patients. About 3.5% had alcohol use disorder. They had some pretty good info. There's a ton of different comparisons they were able to make, and that only 26% of the non-alcoholic patients had a strep pneumo as the main bug when they grew it, but it's 44%. So basically bread and butter pneumonia most of the time.
So that's what I was just going to say. Before this paper, I would have said the common types of pneumonia, H flu, strep pneumonia, and whatever the third one is, if you remember, would be most common, but aspiration is higher in people with alcohol use disorder. And what this tells us is that it's still those common types, but aspiration pneumonia, at least in this sample, isn't more common.
Yeah, no, it's about the same. Okay. And I like the way they define kind of the typical pneumonias. It was basically it was when they grew out a bacteria that was resistant to respiratory fluoroquinolones or ceftriaxone azithromycin.
So I may be dating myself, but whatever this tells us, I'd still need to pull out my Sanford Guide to Antibiotics to figure out what the proper dosing is in 2019 for which agent.
Yeah. Okay.
But I suspect you know what that is off the top of your head.
Yeah, ceftriaxone azithromycin, a gram, 500.
Sounds great.
For patients getting admitted. There's one study from a few years ago with some bench data suggesting you might need to add on coverage for strep, but I'm not convinced yet.
I want you to take care of me if I have that. Well, what do you have next?
Okay, next up, this is interesting radiology study where they use deep learning to help diagnose cerebral aneurysms. Basically, they did 700 or so scans, fed them through into a deep learning module, so it tried to figure out how to see aneurysms on CT head and neck, intracranial aneurysms. And then the meat of the study was they took 115 of those studies and randomly gave them to 8 clinicians. So it was 6 radiologists, 1 radiology resident, and 1 neurosurgeon.
And when you say studies, you mean imaging?
Yeah, CT angiograms. And then basically in a random order, or essentially random order, they had them, each radiologist look at it with what they call augmented, with the image augmented by the deep learning algorithm, and with it without augmented. And then half the group did one first and then did the other, and half the group did it the other way with a 2-week washout period in the middle. So it was pretty good. They were looking at the same studies, but couldn't possibly remember the same thing, and found that the augmentation, which is really just like the computer lights up in red some areas that it thinks that there's an aneurysm, and they can toggle it on and off, and it increased the sensitivity by about 6 percentage points, which is pretty good, without any change in specificity. So they were detecting more aneurysms without more false positives.
So is the finding here that the machine does better than the clinicians, or that the clinicians form the base judgment and the machine on top of the clinicians improves their diagnosis?
The second one. So when a clinician has the assistance of the machine, they did better.
Okay.
The machine alone was more sensitive, but at a big loss of specificity.
Okay.
But when you put the two together, when you say, hey, here's an area I think an aneurysm is, you should look here, the clinicians did better.
Got it. I think we are on a collision course with the age of Ultron, where the or the Terminator, right, where the machines are taking over, at least for image processing.
Yeah, and I think this is all of the. I think most. I'm not a radiologist. I'm not a diagnostician in this kind of stuff, but I know nothing about how AI works. But everything I've seen that seems really promising about this sort of AI isn't AI totally replacing radiologists, but this sort of like, hey, here's the, don't look at the whole thing, but this is the area to really focus on because I think there might be something here.
Yeah, I think there are other people who will say that we should probably combine radiologists and pathologists, the kind of the image analysts who are humans, into people who help the machines do a better job. Right? Eric Topol published a viewpoint kind of along those lines, which is to say we should probably shift the specialty. I don't have any skin in that game, and some of my best friends are pathologists and radiologists, but things are fundamentally changing, at least with respect to image analysis. The applications of deep learning, machine learning to the rest of healthcare is really far away.
Yeah, I think I'd probably like to phrase that as have the machines help the doctors do a better job than the other way around that you phrased it. But
fair enough.
I don't know. That's just the human.
Leave comments if you have opinions about that on any of our platforms, Periscope, Twitter, Facebook, or YouTube.
Yep. And last one we have, this is just an interesting one that came out and was timed to the meeting, but the Association of Repetitive Transcranial Magnetic Stimulation Treatment with major depressive disorder. But basically, this is basically a pilot study where you can take it.
Do you want me to read it for you?
No.
Okay. Subgenual cingulate hyperactivity.
Yeah.
So it's an area of the brain, I think, that's mechanistically associated. Now we get deep into neuroimaging with major depression.
Yeah. So basically, they took 30 patients with major depression, 30 patients without depression.
Yeah.
Did EEG monitoring of the SCH and showed that the people with depression had slightly different brainwave patterns that were kind of consistently different. Then they did two interventions. They did this sham procedure where they pretended to do magnetic waves in that area.
Yes.
And then they actually did magnetic waves. And we did the EEG.
Yes.
And the sham didn't change the waveforms, but the TMS did. So basically, transcranial magnetic stimulation was changing the brainwaves of the people with depression back not to normal, but closer to normal.
Right. Closer, right. So what's intriguing to me is that nobody likes to talk about it, but electroconvulsive therapy, such as you've seen in stereotyped in movies and other kind of literature, is really still an incredibly effective treatment for treatment refractory depression. But this transcranial magnetic stimulation is kind of emerging as a similar technology that is perceived probably to be more humane. Yeah. I'm not sure that it necessarily is, and we're building an evidence base to kind of suggest why that is. Yeah. And what's interesting to me is whether there can be a comparison of the two eventually to understand whether one is non-inferior to the other or superior to the other in terms of outcomes for these really difficult to treat patients.
Yeah, and I mean, this is far out of my area of clinical expertise, but my general understanding when I've talked to psychiatrists about it is that ECT is generally, it's been portrayed and seems to be kind of, I don't know, brutal and weird, and it's really not.
It's not.
It's really not at all, and it's just gotten a bad rap. So I think part of it's kind of like, out-of-pocket costs or availability to get an appointment. If you can't, or the pharmacies, keeping naloxone in stock. You can have the best therapy in the world, but if people are afraid to use it because it seems yucky in a movie, then it's not effective.
Right. And that was, maybe this isn't an apt analogy, but we went on hiatus from thalidomide for 30 years because of the public health problems with congenital defects, primarily in the UK in the early 60s. And then it was kind of headline breaking news when the drug was found to have effects as an anti-neoplastic in some instances. So that's another instance. I think we will rediscover old therapies. Right. And that's happening now for other things too that I'll spare you.
And the thalidomide one makes sense because originally it was causing problems because it was used specifically for pregnant women for morning sickness. So so using it in a non-pregnant population probably avoids the birth defects.
Probably.
I'm not a scientist.
That's a low-risk population. Right. Okay.
Right, exactly. All right, so that's what we've got for this week. Of course, go to JAMAnetwork.com, read these articles and more from our last release. Join us next week. We'll be back Monday, 2 p.m., our usual time. And submit your questions, comments, concerns, follow us, etc. fix my pronunciation, and all usual social channels, Twitter, Facebook, LinkedIn, Pinterest at JAMA Network Open.
And listen to our podcast. This video broadcast will show up on our podcast feeds anywhere you get your MP3 podcasts, Stitcher, Google Play, Spotify, and so on. Check out our translations into Spanish and simplified Chinese of our titles and key points on our website, jamanetworkopen.com. Sign up for our emails and visit us Friday at 10 a.m. Central Time, Greenwich Mean Time -6 for our new releases.
Yeah. Are they actually MP3s? Do we still use that format?
I believe they are.
Okay.
I will ask our audio engineers, but I think of them as podcatchers is what I sometimes call them.
Sure.
Anywhere you get your audio.
Right. All right. Great. Thanks for joining us. Take care.
Thanks for joining us. See you next time.